So the first major criteria is arthritis. So arthritis, approximately, that is the most commonest symptom of an acute rheumatic fever. So 75% of the patients can have of an acute rheumatic fever will have arthritis. So arthritis is one of the earliest manifestations of rheumatic fever also. So rheumatic fever arthritis involves larger joints, that is knees, ankles, wrists and elbows, and it is never deforming. So this is very important. Each and every point in arthritis is very important, okay? And on examination, you will have a hot, red, swollen, very tender joint, migratory in nature, okay? Never deforming. So one day it is present in the knee joint, the next day it is present in the wrist joint. So it becomes normal within 1 or 2 days without any treatment. So the migratory polyarthritis, that is the hallmark. And very dramatic response to salicylates. You give NSAIDs, dramatic response even to low doses of salicylates. So these are the pathognomonic or the hallmark points for arthritis. If you have given salicylates, no response in the arthritis, so please think of any other alternative diagnosis, okay? And if the arthritis is very severe, the carditis will be less severe, okay? So they have this inverse relationship. So inverse relationship between the severity of arthritis and severity of cardiac involvement. So if we do a synovial fluid examination, okay, what happens? There will be increased WBCs which are seen. So 10,000 to 1 lakh WBCs will be present. Protein will be high, that is 4 gram per deciliter. Glucose level can be normal and a good mucin clot will be present. In moderate or in the high risk population, even monoarthritis or the polyarthralgia can fulfill the major criterion, okay? So this is about arthritis. Coming to carditis. Carditis, in the revised Jones criteria, we take even subclinical carditis, that is without a murmur, with echo evidence of any valvular involvement like regurgitation, can be taken as a positive point. And carditis and the resultant valvular involvement is the most serious manifestation of rheumatic fever. In rheumatic fever, there is going to be pancarditis, starting from the valvular involvement, endocarditis, myocarditis, pericarditis. So all the areas of cardiac involvement will be seen. What is universal is valvular involvement. So valvulitis or the endocarditis is going to be the universal finding in rheumatic carditis. So which valves are most commonly involved in rheumatic fever? Most commonly it is isolated mitral valve or combined aortic and mitral valvular disease. Isolated aortic or right-sided valvular involvement is very uncommon in rheumatic fever, okay? You also have to think of any alternative diagnosis when this is the clinical scenario. So what happens when there is a valvular involvement is, most often it is a valvular insufficiency, that is regurgitation will be there, mitral regurgitation or mitral plus aortic regurgitation. This is seen in the acute stage. What will be seen in the chronic stage? Years after the acute illness, when the rheumatic heart disease has set in, we get valvular stenosis, MS and AS. Acute stage we get insufficiency, okay? So this is about carditis. So carditis, again, when compared to arthritis, carditis is seen in only 50 to 60% of cases. Arthritis is seen on almost 3/4 cases of rheumatic fever. So carditis is seen only in 50 to 60% of cases of acute rheumatic fever. In any rheumatic fever, we have to screen for carditis, do a ECG, do an echo, okay? The patients will have tachycardia, the patients can have murmurs, and with or without evidence of myocardial or pericardial involvement. So the murmurs again will be dependent on which valvular involvement is seen. If it is a mitral regurgitation, there will be a holosystolic murmur or the pansystolic murmur which is seen in the apex, apical holosystolic murmur radiating to the axilla. If it is an aortic regurgitation, we get a diastolic murmur at the left sternal border. So these are the murmurs that we see in rheumatic